Good afternoon once again. I think we are ready to start now. I'm going to call my panel members to join me on the stage so that we avoid moving up and down. May you please join me? Yeah. So we are going to have Dr. Loveleen, who is going to be our first speaker, Dr. Yogan Pillay, Dr. Mgurungi, Tamara, Miss Tamara, and Professor Mlinga. I haven't seen him yet, but if he's around, he's going to join us. Thank you so much. Thank you for joining me. Thank you, Prof. You can come through. You can come and see.
He's walking now. Kenley, what did you do to Kenley?
Pardon? Don't worry, there's another chair there. Okay, good afternoon once again, and thank you so much, panel members, for joining me. I'm not sure if there's anyone joining us online. We have tried to sort that out, but it looks like we don't have online people joining us. So I'm just going to greet those who are here, but if there are people joining us online, greetings to you. I'm Edna Mdimu from the University of South Africa, and today I'm standing in here as the chair for the HIV Modelling Consortium. And some of you might be asking yourselves, what is the HIV Modelling Consortium about? So I thought maybe it would be helpful for me to briefly provide some background information about the HIV Modelling Consortium. The consortium was originally convened by a secretariat that is based at the Imperial College, London, under Prof. Tim Hallett in 2010. So it is about 15 years old now. And the consortium exists to inform HIV policy through rigorous evidence-based analysis. So as you can see from the name, it's HIV Modelling Consortium, which means we are going to be dealing with mathematics. But I'm sure today my speakers are going to make it light for you and you'll be able to understand what is the work that we do. So since its inception in 2010, the HIV Modelling Consortium has worked in partnership with country programs. May you please go to the next slide? It has worked with mathematical modelers, UNAIDS, and the World Health Organization to provide some timely evidence that informs strategy and resource allocation. The work for the consortium spans epidemic projections for the HIV, cost-effectiveness analysis, and scenario planning. All they are tailored to real-world decision-making. For more information, I'm going to refer you to our website there. And on that website, you can also see some resources that can guide you in how you can start mathematical modeling if you're interested in mathematical modeling. So for this particular satellite session, we'll show how mathematical models have used epidemiological, behavioural, and cost data. I know that most of you work with data, you collect data, and we are sort of the end users. We take the data that you have collected and to inform the models and then give you some feedback after doing some modeling. So the panel that I have here, they bring some diverse voices, including a senior mathematical modeler, which is Dr. Loveleen Mataru. We also have a health economist. Unfortunately, she was supposed to join us online, and as I've indicated, we are having some technical challenges, so she's not going to be able to speak. We have, from the funders, we do have Dr. Pillay, who is from the Gates Foundation. We also have a community advocate, Ms. Tamara, who is going to tell us how our modeling informs them in their community work. We also have directors of national AIDS programs from sub-Saharan Africa who have actually had an experience in using the models that we run and develop. that is Prof. Mulinga and Dr. Mugorongi. I'm so delighted to welcome all these exceptional panel members. Thank you so much for coming. I think you can give them a round of applause before they start talking. Thank you. I'll start with Dr. Loveleen, our senior HIV modeler, who will discuss how epidemiological and behavioral data are integrated into models and how modeling helps address the key implementation questions. Over to you.
Thank you, Edna. Just waiting for the slides to come up. There we go. Thank you, everyone. I've only got a very short time, so I thought I would use it to try to explain how mathematical models are useful in guiding policy. Next slide, please. Let's say we have a randomized controlled trial that shows a beneficial effect of a particular drug. So a new policy might be introduced a new policy might be discussed to introduce that drug. But in order to introduce it, we need a lot of discussion around the health benefits of that policy, as well as the costs and negative health impacts. And this is really where modeling comes in. So when dolutegravir did very well in HIV trials, as policymakers, we want to know not only the beneficial effects of dolutegravir, but also the negative effects that it may have and how they may impact on existing HIV treatment programs, as well as the cost effectiveness of the drug. Next slide, please. So policymakers may not have the expertise to quantify those outcomes. Those decisions are not straightforward, they're not black and white, there's a lot to think about. And there's often a trade-off between the positive health benefits of the drug and the costs, both in terms of health and the negative consequences of introducing that drug. And so it's helpful to know what may happen in the long term. The trial shows what happened in a very predefined population over a relatively short period of time. But what we're really interested in is what happens in 5, 10, 20, or even 50 years' time in the long run we introduce that policy. And that's really where mathematical modeling comes in. Models can be used to predict the outcomes over the long term, looking both at the positive impact of the drug, but also any negative impact it may have, as well as the costs. And it's important to note here that the policy decisions aren't just based around the cost effectiveness or models. There's a lot that goes into it. But over the last few years, I think models are becoming increasingly important to help guide policy. Next slide, please. So this is a very oversimplified diagram of what a model is. We start with a real-world problem, and that might be HIV incidence going up, for example. And based on our understanding of that problem, we try to express it in epidemiological terms. So we look at the probability of acquiring HIV, how it progresses over time, what happens to the population who don't have HIV concurrently. So we identify data to inform models and often have to make assumptions where that data is not reliable or doesn't exist. Then we run the model, so we may run the model with a status quo scenario and compare it with an intervention scenario. We analyze the outputs, interpret results, and help inform policy. Of course, in real life, it's not that simple. This is a very simplified diagram, but it does give you an idea of how models come to play. Next slide, please. So there's several well-established HIV mathematical models, modeling settings in Africa. Most of these are listed on these slides. They vary in assumptions, in structures, and most models actually are calibrated to more than one setting and have extensively been used to inform policy. Next slide. Now, in recent years, as Edna mentioned, we have the HIV Modelling Consortium, and this is where those models that you saw in the last slide have come together as part of the consortium. So instead of one model tackling the same question, we have multiple models looking at the same question. And this is hugely beneficial because we have model outputs from an array of models with different structures and different assumptions. And if in agreement, we're able to provide very robust evidence to policymakers. Next slide, please. So over the last few slides, I thought I would give you some examples of projects that the HIV Modelling Consortium have undertaken and the impact they've had on policy. Now, the first is medical male circumcision, and this was a project done a few years ago, so before the funding cuts. And PEPFAR approached us with this question of interest, that given the scale-up of treatment programs and the limited HIV program resources, does the provision of voluntary medical male circumcision continue to represent a cost-effective use of HIV program resources? So we had 5 modelling groups tackle the same question, and they all looked at 2 scenarios. No further VMMC in any age group and continuation of VMMC for the next 5 years per 100 person years, but in 95% of settings with HIV incidence greater than 1. Next slide, please. So as well as publishing the paper with those results, we were able to provide a guidance to PEPFAR, and our results featured in their COP22. And along with other evidence, we were able to contribute to the continuation of VMMC funding over the foreseeable future. And so that's really an example of how modelling directly influences policy. Next slide, please. Sorry, next slide again. That's a repeat. Next slide. The second example is about analyses that took place during the COVID pandemic. As you all, I'm sure, well remember, it was a time of great uncertainty, and we wanted to be able to advise policymakers what services to keep going in a time where there were global lockdowns going on. So the question that we were interested in was, what are the potential effects of disruptions to provision of HIV services due to COVID-19 on HIV-related deaths and new infections? Again, we had several models looking at the same question, and they all considered potential disruption to HIV prevention, testing, and treatment services, and looking at different rates of interruption as well. Next slide, please. This is the main results slide from the paper, and I know you won't be able to see it very well, but it looks at the relative change in mortality across the bottom and the disruption to services across the left-hand side. So we've got disruption to VMMC, condom availability interrupted, suspension of HIV testing, and so forth. But the key message to take away from this slide is that all models agreed that disruption to ART services had the biggest impact on mortality, and we were able to provide very clear evidence to policymakers. And that's quoted directly from the paper, that during the COVID-19 pandemic, the primary priority for governments, donors, suppliers, and communities should focus on maintaining uninterrupted supply of ART drugs. Next slide, please. So just a few final notes. As you've seen on those slides, modelling can directly influence policy, and the use of multiple models particularly strengthens the reliability of these findings considerably. It allows models to evaluate their own and other models, and particularly the underlying assumption of those models. And this is considerably more time-consuming than any single model analysis, but that's balanced by the robustness you get at the end. And often models may not be aligned perfectly, so as modelers, I think we've come to manage our expectations and really focus on the interpretation of those results. So it's important to interpret outputs with an understanding of the context under which they were generated, so having some idea of the model limitations. Thank you.
Thank you so much, Loveline, for such an elaborate presentation about modeling. And I'm sure those that are not in modeling, you have managed to catch 1 or 2 things from her presentation. Just to inform you that we managed to get Gesine online, and she's going to talk about how she uses her health economics and in collaboration with the modelers to make decisions for governments. Gesine, can you hear me? Are you able to connect here? We apologize for that. they indicated that she managed to join. I think they are trying to change over. So just speaking on to what Lovelyn was talking about, she talked about multiple model comparisons, and that is some of the work that we do. As she indicated, models, they do have different assumptions, but for the models that we currently have, we find that if we run some simulations, we do not agree 100%, but you'd find that all our trends will be sort of following the same shape. So at the end of the day, we are actually able to make some conclusions from what the models are giving us, even if they've got some different assumptions. Are you winning? Or should we go to the next presenter? The next one. Should we take the next presenter? Okay. Our next presenter is Dr. Mgurungi. I wanted us to talk about the health economics before we go to the actual implementation, but anyway, we are going to look at how people are using the model results that we are generating to inform their policies. Over to you.
Thank you. Thank you so much. Good afternoon, ladies and gentlemen. My slides are coming through. My name is Owen Mugurungi. I'm the Director for AIDS and TB programs within the Ministry of Health and Child Care from the Republic of Zimbabwe. I'll just, no, that's not mine. I'll just share some practical experiences that we have had with modeling. Let me start by saying that in our national context, modeling has become an integral and important part of our work because it allows us to use tools that are critical for us in setting our priorities, our targets, and also optimizing the use of the limited resources available. We know that for most of us in this room, every year, UNAIDS produces estimates on HIV and AIDS, which have become so famous across countries. And that's an example of how we use models to estimate and say, where are we, what is it that we have achieved, and where do we want to go? They are also a very important resource mobilization tool and a monitoring tool in terms of our work. Next slides, please. Can I have next slide? Yeah, so I was saying that models are important for us in setting priorities, targets, and optimizing the use of the available and limited resources. They are also important for us in defining trends, patterns, and measuring progress towards our national strategic plans. We use them as very important resource mobilization tools, and of course, they assist us in reporting to our funders and also globally to the UNAIDS towards universal progress towards ending HIV and AIDS. And they are, of course, a very important tool in advocacy and trying to make sure that we change policies. Next slide. Here I'm trying to show where we have used models, and of course I'm not a health economist, but in essence, taking from health economics, we can be able to calculate the DALYs and also say what is the most effective intervention that we need. And you see that in terms of HIV, here programming, you you see sex work, index testing, self-testing, pre-exposure prophylaxis are very important interventions that we use when it comes to HIV prevention. And as you go down, you see that there is less cost effectiveness because there's incremental cost. But this is important for us to make sure that we introduce and scale up the interventions in terms of the limited resources that we have. Next slide. Another example, in voluntary medical male circumcision, they also assisted us, and in Zimbabwe in particular, we are now know that based on our epidemic control, we now know that because we introduced VMMC in Zimbabwe, we were able to avert more than 100,000 new HIV infections over the past 10 years. And now go back. And this becomes a very important advocacy tool because we are able to show and get our partners and donors to say this is what we have saved and this is what we could have incurred and this is where we are because of VMMC. And you can also see that we did very well in trying to make sure that we have less HIV infections and savings that potentially could have be attributed or could be used for HIV treatment. And next slide. In today's world, we know that we don't have all the resources, but we still remain focused in trying to get our targets of ending AIDS by 2030. And again, we've been told to reprioritize, relook at what we are doing and try and see where you can have cuts and where you can integrate, etc., etc. And from this, you will also see that this is a modeling example where we said if we maintain the status quo of the interventions that we have, Zimbabwe will not get to ending HIV by 2030 to actually get there in 2041. Funding to most of our programs. And then we also wanted to know what would be the impact. So we see that had we continued with their funding, we would have continued with decrease in new HIV infections. But the cuts, because they happened, there will be an increase in new HIV infections. And our incidence, which was 0.87, would actually go to 1.87 within 1 year if the cuts continued being permanent for 1 year. And if the cuts were permanent and nothing is done, we would actually go to an incidence of 1.55. So it's a very important tool for us to mobilize resources and to remind our governments and partners that we still need to do more. Next. Next slide. Is that the last slide? Okay. The last one is, of course, Lovelin's already talked about VMMC, the work that we did with the Modelling Consortium in terms of VMMC, because people thought, well, we are done, we had set targets for VMMC. But this really showed us that despite the fact that we had achieved the number of circumcisions that we required, we still needed VMMC to be part of that comprehensive package so that we can maintain the gains and also continue with the decrease in the number of new infections. I think that's all I have for you in terms of practical examples from Zimbabwe. Thank you very much.
Thank you so much, Dr. Mkurungi, for sharing some examples from Zimbabwe and how you have used modeling. I think we are running out of time, so I'm going to hand over to Prof. Mulinga, who is the director of the HIV program in Zambia. And if you can be a bit fast, Prof, I would really appreciate that. And you don't have slides, right?
Thank you so much. I think for me, what my brother from Zimbabwe, Dr. Mkurungi, has highlighted is just what I would like to just emphasize on. During this time when we have had changes to our funding landscape, that's when I've seen more utility of data coming out from modeling. When we were asked to reprioritize our interventions, first from the Global Fund, but also from our government as well, we needed to have evidence on how we were prioritizing some of the services. And really, that data-driven framework is needed for someone to come up with these most cost-effective strategies. And during this time, we have looked at various populations that we needed to look at. Which population did we need to invest more in? And using modeling data, unlike Zimbabwe, for us, we found that investing in medical male circumcision was not going to give us much value compared to other interventions as well. So we had to use modeling data. And we used that as well in coming up with our HIV basic minimum service package. So we had to, again, see which interventions can we do. Like when we had to look at the testing, when we started PrEP, we started using the NAT testing, the nucleic-based testing for injectable PrEP. But again, with the changes in the funding landscape and also the complexities which come as well and the data which we use, we found that there was no utility of us moving in that way. So again, those are things which we had to implement, especially with the changes in the funding landscape as well. But also, you know, it's not that just the implications which are brought in when you have this model data. It's quantifying the outcomes and costs, which rarely as programs and as ministries we don't do. But with the modeling, we're able to advise our policymakers on what cost-effective interventions we need to invest on and what the outcomes would be as well. And that has led for us to have optimal resource allocation. I know it's not easy, especially that you have to do some sensitivity analysis, like when we looked at our HIV basic minimum package and also our introduction of LAN as well. We had to see how much would it cost for us to invest in community programs compared to us investing in facility-based programs, and looked at the outcomes. How many HIV infections are we going to avert? And also, if we do not invest in each of those, how many were we going to get HIV, and what would be the cost of maintaining someone on treatment as well? So those sensitivity analyses, they made us come to a conclusion that possibly this is what we'd get. But that is model data. And right now we are moving into where over the next few years, we will be analyzing outcomes depending on the interventions which we are providing in the different areas in the country. Some facility-based, others community-based, and we'll look at all those outcomes. And possibly now we'll have real data coming from a program on the cost effectiveness of delivering of these services. So this is how modeling has helped us, and we intend to use it more often in many, many areas. Thank you.
Thank you so much, Professor Mulenga, for giving us some experiences from Zambia. We are now going to quickly move on to the funders. As you have heard, everyone was talking about funding. So we now need to know how the modeling work is informing the decisions that they make in terms of which programs to fund when they are funding the different countries. We move on to the Director of HIV and TB Delivery at the Bill and Melinda Gates Foundation, Dr. Yogan Pillay. Over to you.
Thanks very much, Adina, and good afternoon, everyone. The Gates Foundation is both a funder of modeling and also uses modeling to decide what we can be prioritizing. So, as I'm sure many of you know, Bill has decided that the foundation will sunset in 2045, and he's given $200 billion to cover that 20-year period. So, all of the program support teams in the foundation, including the one that I lead on TB and HIV delivery, have to present to Bill and the leadership every October on new strategies and our new strategic plans. And this October, we were asked to think about what it is that we would be funding or should be funding or could fund over the next 20 years. And what would that do, and in my case specifically for TB and HIV, on reducing incidence and reducing mortality? So those are the questions we were asked to model. So we, of course, tried to model, anticipating the pipeline on R&D, because the assumption being that new products could drive down, if implemented with efficiency and fidelity, could really bring down the incidence and mortality. And of course, the second part of it is how do we use existing tools more effectively and more efficiently. So we did all that and then presented, of course, to Bill. Of course, it was built on a large number of assumptions. Now, what all these good people didn't tell you yet is that sometimes the modelers can get it very wrong. So we also need, and you saw that during COVID, there were multiple models during COVID, and some of the models got it very wrong. So modeling is not, it's an art as much as it's a science, right? Which means that we have to also think about what else we can do to get our estimates or predictions or conclusions somewhat more accurate. So, and I'm saying this because as a user, because the foundation and I are users of modeling outputs, we've got to think about them rather rationally. At every occasion when we present during the strategic planning sessions with Bill, we have to do two things. We've got to model, and we've got to show the ICASA, the incremental cost effectiveness ratios, to show that what we are suggesting to the leadership in terms of how the foundation should use its dollars will give us the best possible impact. So we don't only fund modeling exercises for countries that need it to make decisions, we also use models to determine our priorities and what we will fund as the foundation. So the environment in which we are currently in is, as has been said multiple times already in this conference, highly constrained with respect to not only the finances, but also in terms of human resources. So we need to think about these things a little bit. At the same time, it's very exciting that we have new developments on the tools side. So talking about TB for a minute, there's some very exciting news on the TB scenario. We have the potential of TB vaccines. There's one TB vaccine, M72, which the foundation is currently funding, which is in phase 3 trials, and we should get the results, the preliminary results, somewhere around 2028. We are funding a pan-TB regimen for both for drug-sensitive TB as well as drug-resistant TB, and we are funding low-cost point-of-care or near point-of-care diagnostics for TB. Key question for countries is, with these new tools coming in around the same time, led by the diagnostics, is how are they going to afford it? Is this going to be a replacement for existing tools, or is this in addition to existing tools? So it's something that we in the foundation have already started thinking about, so that we don't start thinking about these kinds of things in 2028 when these tools are about ready for deployment. So that's another example of how, linked to R&D, we on the delivery side are thinking about how countries, end users, will use these tools. So modeling helps us make sense of the uncertainty, and there are many uncertainties right now. But it gives us, I think, a structured way to explore at least three things. One, how epidemics may evolve if current trends continue, and what can we expect for new pathogens? And there's a lot of interest right now in new pathogens. Not so much on HIV and TB, even though we still have big challenges with them. Secondly, how outcomes might shift if we introduce a new diagnostic, a new drug, or a new vaccine. And thirdly, and what combinations of interventions appear most promising under different assumptions. So modeling, as far as I'm concerned, don't make exact predictions. Instead, they help us to understand the range of possibilities and the direction of impact, allowing decisions to be grounded in evidence, such as it is based on the assumptions we make, rather than pure guesswork. So I have a range of examples of how we can use it in choosing either between drugs, diagnostics, and vaccines, or between different types of diagnostics, different types of drugs, and different types of vaccines. And countries are sitting with these right now, as we've heard from both Lloyd and Owen, and will increasingly have to make choices. And I think that's really where we can use models most productively, in how countries can make choices given the restricted amount of funding they have. We have the same challenge right now with respect to lenacapavir. How do we decide, with the small amount of volume that we have and funding constraints with lenacapavir, how do we decide who it should be afforded to, who should get lenacapavir? So there's a number of modeling studies that have looked at this, and ultimately, my guess, Lloyd, is that this will be a political decision, as much as it's driven by modeling or any other empirical evidence we might present to ministers of health who have to ultimately make this decision. So we shouldn't forget that models are very useful. We all should be using them, but ultimately decision makers will use modeling as well as other criteria to decide on choices that they would have to make in the context of the people they want to serve. So the essential foundations of models are reasonable quality data. Otherwise, modelers are going to use wide-ranging assumptions that might get us all into a lot of trouble. And the key question that precedes modeling is, what data do we need to drive some of these models? And who funds it? At the moment, there's a lot of discussions about implementation science research, and I think we need to all put our heads together to think about, intentionally what implementation science research we need going forward, not just to 2030, but beyond 2030 for HIV elimination or reaching epidemic control, however we want to phrase it. So my call is for reasonable quality, consistent, and timely information to produce meaningful directionality. Good data, whether from surveillance systems, programmatic records, surveys, or lab networks, helps ensure that modeling outputs reflect the real world as closely as possible to guide decisions. I think we need to do some de-risking. We need to de-risk some of the innovations, and we need to shape markets, and modeling allows us to test what-if scenarios before committing significant resources. So we can explore, I think, three things. What if uptake is lower than hoped? What if real-world performance differs from trial results, and we've seen that often enough from randomized controlled trials? And thirdly, what if prices remain high for much longer than we anticipate? And I think these insights will help us shape product profiles, guide negotiations with manufacturers, with the pharmaceutical industry and the diagnostics industry, and adjust our expectations. They reduce risk by helping us understand the range of possible outcomes. Any modeler who gives you one outcome, I think, should be asked about what are the other alternatives. In terms of allocative efficiency, and I think Owen spoke about this across the portfolio, modeling helps us look across diagnostics, treatments, and vaccines to assess which combinations appear most promising at various budget levels for various target audiences. It does not tell us with certainty what the single best allocation is, but it helps highlight three things: where diminishing returns might set in, which interventions seem consistently strong performers, and thirdly, where synergies may exist between tools. This directional guidance supports governments and global partners in making balanced, evidence-informed choices. And finally, modeling helps us identify the populations and areas, the geographic areas, that seem most underserved or have the most vulnerable people or people with the worst outcomes. It flags where interventions are likely to have the greatest incremental benefit, whether that's a diagnostic in a high-burden area, a long-acting drug for populations with adherence challenges, or a vaccine targeted to groups at highest risks. These are not absolutes, but they provide a strong rationale for targeted, equitable investment. So in conclusion then, modeling is not about certainty, it's about clarity in uncertainty. It gives us direction, shows us relative advantages, and helps us make more responsible, impactful decisions possible, especially when resources are constrained or new tools are emerging. When paired with reasonable quality data and thoughtful interpretation, modeling helps ensure that every diagnostic, every treatment course, every vaccine dose, and every dollar moves closer to the outcomes we seek. Thank you very much.
Thank you so much, Dr. Pillay. We are running out of time. We can't do all this, that the modeling we are doing without considering what the community says. So we are going to listen to Ms. Tamara Cho. She's the last one, but not the least. So we really value your presence.
Thank you so much. And we are glad we are all embracing modeling. We are, right? I still have a few people that look at modeling as complex mathematics. And to them, I try to explain it as similar to the weather forecast, right? So the meteorologists will tell us tomorrow it's going to be partly cloudy, it's going to rain. Not that they've been to the future. It's just that they use data to predict some of these things. I think it's the same thing with the modelers. So they will use data to predict these conclusions and solutions. And I try to explain that modeling is really an important tool that we can use to get solutions, and not just any solutions, the right solutions. So I am Tamara, and I serve at AfroCab, and I'll just be talking about how we can use modeling in advocacy. Next slide, please. So we, as AfroCab, are a community organization, and we work around access as well as equity. Next. And we know that in reality, there is a gap in terms of equity, and not everybody is benefiting equally. And this is where our work starts. So we do advocacy around the inequalities as well as the persistence disparities. Next slide. Yes, so I know there are many types of advocacy, right? But we all know that now evidence-based advocacy is really taking the lead. And we've seen that we are more likely to get positive responses from our policy makers when we do evidence-based advocacy. And as AfroCab, we really have invested in this. So what is it that evidence-based advocacy has given us? So we know that when we use evidence, and this evidence can be from modeling, it can be from research as well, but when we use advocacy, especially for modeling results, we now know that this makes our arguments even more believable, right? They're hard to dismiss if there's evidence embedded in them. It has also influenced the community voices, and it has helped us to engage with policymakers much more effectively. And this time around, we sit on those tables. There are no scenarios where we are told we are going to have another meeting for the communities because you will not understand the complex mathematics. But I think the communities are really embracing modeling, and they are part of the decision-making tables. So evidence really transforms these requests into compelling and very authoritative demands. And I think we've seen that as we do evidence-based advocacy, even our relationships, even the invitations that we get from the governments starts to come in. Next slide, please. So advocacy really is very blunt without modeling. And modeling, I can say, supercharges advocacy. We know that through modeling, we are able to quantify the inequalities. So we're not just saying women are not reached, but modeling will tell us how many, where they are, and what we can do to reach them. It also gives us the consequences. So if today we decide not to do anything because of the funding cuts, there is a cost to inaction, and modelers can tell us what that cost is. Okay, so it can also compare solutions. So again, not just solutions, but which solutions are the best. So modelers have been able to give us this information, and we've been able to use that information to advocacy work. Then there's a cost that is involved. So it can calculate the return of investment and show us the cost of equity, as well as optimize resources. It can show us how to get the most impact from each dollar we invest. Next slide. So this is just an example, right? If we have an advocacy ask, for instance, where we need to get more women on PrEP, these are black women, without modeling, without the numbers, the advocacy message would just be, please, PrEP uptake is low among black women. That's quite blunt, right? I mean, I've heard some of our policymakers say, you're just making noise. Sometimes what we hear is, you're just speaking from without, because our messaging is very blunt. But with modeling, the same message can be stated as, our models reveal that black women are 15 times more likely to acquire HIV than white women, yet less than 8 times less likely to be prescribed PrEP. Closing this gap would prevent an estimated 1,200 infections in our country over the next 5 years. I sound intelligent, right? And this is what our policymakers want to hear these days, so they don't call us noisemakers. So we need to really embrace this modeling. I think it's here to really package our messaging so that it's understood and taken well. Next slide, please. So we have a relationship, a marriage with the modelers and the policymakers. And we know that it's the duties of the communities as well as advocates to identify the problems in the communities, right? Once we identify those problems, then we can give them to the modelers. And the modelers will take that and they can run scenarios and tell us, and test the solutions. Thereafter, we have partners that can now translate this information, and then the advocates again come in and it's working. Yes, so advocates can come in and now use this evidence from the modelers to ensure that the policymakers are informed about this. And this can be done through meetings, the policy briefs, as well as campaigns. And the policymakers work on this. So this is, we have a very strong relationship between the modelers, the advocates, as well as the policymakers. And the cycle just goes on and on. So modeling provides the evidence for advocacy, and advocacy provides the context. So that's what our relationship is, and we should all embrace modeling. Next slide, please. So in conclusion, when modelers come into what we do, and we need that evidence, our please help, when advocacy is just please help, is transformed into this is what the problem, this is what the plan is. And I think it's nobody can dismiss that kind of packaging. So by combining the heart of advocacy, advocacy comes from the heart, right? It's passion. And the rigor of data comes from here, from the brain. We can build a stronger case. And I think our policymakers are much more able to engage with us. They are, I consider them the legs of the interventions that we need to do. So we have the heart, from the heart to the brain with the data, and then the legs. They take us where we need to go. So thank you very much, and I'll end here.
Thank you so much, Mr. Amara, for showing us how you are using modeling in the work that you are doing. Unfortunately, we have run out of time. I'm just going to take one burning question, if there's one burning question in the audience. We are really, really behind time. It looks like we don't have any questions. Maybe just to close, I picked from Dr. Pillay. He indicated that models, they are not giving you 100% answers to your problems, or they are not 100% perfect, in other words. So the approach that we have used with the modeling consortium is to do what we call multimodal comparison, which Lovelyn spoke about. If you can see that you have got 5 models that have got different assumptions but giving you similar results, that will actually increase the confidence that you can have in the results that you're obtaining from these models. So the HIV Modelling Consortium tries to work on that, but as she indicated, it takes time. So if you want immediate answers, for us to take all the models together and compare the results might take more time. But we use that to test our models to see if our models are doing what we are saying they are doing in each of the countries, so that when you come to us and say that you need some solutions, we can easily pick one of the models that we think is the best one to answer your questions, and we can use that. And we have confidence in it because we have compared its results previously with other models. So that is what the Modelling Consortium is doing. And we really look forward to policymakers, to advocates to come to us, and the funders to tell us, where do you want to see modeling going for the HIV Modelling Consortium? I'm not going to waste more of your time, but I've shown you the website for the HIV Modelling Consortium. If you need more information, just visit our website. And we are always open for people who want to use our expertise. Thank you so much. Enjoy the rest of the conference. This is just the first day. We still have about 4 or 5 days to go.